I want to welcome all our CSA members who have taken the time to view this video either on our website or our Facebook page. Today, we will discuss understanding social determinants of health and AHIMA's advocacy agenda. My name is Erwin Arizo, and I have been recently elected as Advocacy Director for the Component State Association Board of Directors. The learning objectives for today are that by the end of this presentation, you will be able to define social determinants of health and explain their importance in healthcare, describe the benefits and challenges of capturing, using, and exchanging SDOH data, and identify AHIMA's position on public policy regarding SDOH and discuss how current health policy advances these efforts. The social determinants of health are defined as the conditions and environments where people are born, live, learn, work, play, worship, and age that affects the wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health are grouped into 5 domains, all of which make a powerful impact on people's lives. Economic stability, education access, healthcare access and quality, neighborhood and built environment, and social and community context. Next, I would like to highlight some of the impacts of social determinants of health on individual, community, and population health. Let's start by looking at the following infographic created by the Bay Area Regional Health Inequities Initiative. This was presented in a position paper by the American Academy of Family Physicians. AAFP's position paper discusses a stream of causation for how social factors impact health. The downstream factors indicated on the far right of the diagram include things like disease, mortality, and poor nutrition, which are typical topics in public health discussions. By looking at the far left of the diagram, where it is labeled upstream factors, we get a better idea of what social factors may contribute to poor health. These upstream factors include inequalities based on class, race, or immigration status. Structural determinants of health play a big factor in causing these inequalities and include things like the decisions government makes on where to dispose of toxic substances, policy decisions about the quality of drinking water, or whether the government will subsidize healthcare. The effects that SDOH has at the individual level are the most identifiable, as these are the things that we see every day affecting our patients, friends, family, and even ourselves. Because each person has a unique identity, there can often be multiple groups that a person belongs to that may impact their health, such as gender, race, class, or others. This overlapping membership in these various groups is called intersectionality. When considering the individual impacts of SDOH, a person's membership in any one group should not be considered separately. For example, a low-income Hispanic woman will have different disadvantages and be subjected to different discrimination than a middle-class African-American woman or a high-income Hispanic male. The AAFP position paper also explained the concept of embodiment. Embodiment is the concept of how humans biologically incorporate material and social factors into their person. When people are exposed to chronic stressors, the body physiologically responds to those stressors, which can lead to negative health impacts. Chronic stress can lead to a person's increase in allostatic load, which is defined as the cumulative burden of chronic stress and life events. This burden accumulates over time, leading to health-damaging effects. There are also many ways in which social determinants of health can impact the community. If aspects of the community negatively affect physical, social, or work environments, this can lead to the detriment of a community's health. One example of this is neighborhood safety. If a neighborhood is unsafe, for example, it can lead to people being less likely to take walks, which would improve their health. Another aspect of a community that can negatively affect health is inadequate public transportation. The lack of available and safe travel, like a bus or train, may prevent people from being able to visit their doctor for either routine care or to treat illness. Another factor to consider is whether there is a lack of basic healthcare services, such as vaccination programs or educational resources. At the population level, SDOH has great impact on predicting health outcomes. Socioeconomic status is one of the strongest predictors of health worldwide. The health of the economy also impacts population health. When our country's economy is struggling, the health of the population suffers in a variety of ways, including people being unable to afford their medication. Life expectancy can decrease based on SDOH factors, which can affect the size of the population. Next, I would like to explain the benefits of capturing, using, and exchanging SDOH data. The first benefit is providing holistic, person-centered care. This vital data must be shared to get a full picture of how an individual's social factors impact their day-to-day life. Second is addressing existing health equity gaps stemming from issues like lack of quality health insurance, living in a food desert where healthy food is not available, or not being able to get time off work for health appointments. Finally, the understanding and study of the effects of SDOH can impact the entire healthcare system and lower healthcare costs. A study in 2019, for example, found that food insecurity, which can lead to chronic health conditions, costs the healthcare system more than $50 billion a year. Next, I will discuss the challenges of capturing, using, and exchanging SDOH data. One of the main challenges is privacy risks. It is extremely important when collecting and exchanging this sensitive information that every effort is made to keep the data secure. Another challenge is the lack of consensus on how to collect data and, as a result, there is a lack of sufficient training programs to instruct those doing the collecting. One final challenge is the lack of standardized definitions of various components of SDOH data, or even what is the definition of social determinants of health. AHIMA, which is the American Health Information Management Association, is aware of these challenges and has issued a detailed policy statement. This policy has 8 factors or goals that AHIMA believes must be present and propose public policy surrounding SDOH data in order to improve the collection, sharing, and use of that data. Their first goal is to establish global standards to promote the capture, use, maintenance, and sharing of SDOH data. This starts with having a standard set of definitions for the components of SDOH so that everyone categorizes data correctly. There also should be an examination of current gaps in medical coding to properly document SDOH data. Any further updates to vocabularies and code sets must be made while taking into consideration the specific needs of SDOH data. It is also a priority to have standardized data elements for electronic health records so that SDOH data can be exchanged electronically. The next area of focus for AHIMA is to, number 2, promote healthcare delivery and financing models designed to integrate SDOH data into the clinical setting in ways that are culturally respectful. This goal is best achieved using patient-centered care models, which encourage the incorporation of SDOH data into healthcare decisions. According to AHIMA's policy statement, public policy must also, number 3, build patient trust and foster positive patient-provider relationships to encourage patients to share their social challenges. Without a trusting relationship between patient and provider, the information needed to properly understand SDOH will never be communicated. Providers must explain to patients the purpose of collecting SDOH data and the benefits of sharing this information for patients to feel more comfortable discussing their social challenges. Another important goal is to, number 4, enhance the sharing of SDOH data across clinical and community-based organizations and service providers. In some communities, non-clinical organizations may have more access to certain aspects of SDOH data, and it is crucial that these organizations have a method to securely share this data with healthcare professionals. It should come as no surprise that one of the key components that AHIMA emphasizes is the need to, number 5, prioritize privacy. One of the cornerstones of the health information field is the necessity of keeping patients' information private and ensuring only the minimum of information necessary is shared. This same principle applies to the sharing of SDOH data and should be considered even when dealing with data that is outside the scope of HIPAA. The next policy point is the need to, number 6, recognize workforce training needs. Those collecting the data need to be taught how to be both accurate and consistent in their data collection, but also how to be culturally sensitive when asking questions about these personal areas. It is also crucial to educate employees about the importance of confidentiality when sharing information with non-clinical organizations. AHIMA also believes that it is important to, number 7, promote the ethical collection and use of SDOH data. There is the potential that this collected data may lead to the creation of social risk profiles that could lead to discrimination and increase existing health inequities, which is counterproductive to the reason for collecting the data in the first place. Finally, AHIMA states that it is crucial to, number 8, embrace the role of health information professionals. Any new approaches or standards must consider the important role that health information professionals play in the capture, exchange, use, and analysis of SDOH data. My last topic regards current health policy advancements. Healthy People 2030 was created by the Office of Disease Prevention and Health Promotion, a division of the Department of Health and Human Services. The framework of Healthy People 2030 identifies 5 key areas to improve the health of all people: health disparities, health equity, health literacy at the individual level, organizational health literacy, well-being, and the social determinants of health, which I have just discussed. The Gravity Project is an open public collaborative advancing health and social data standardization for health equity. One of their initiatives is integration with the HL7 International's Fast Healthcare Interoperability Resources Accelerator. This initiative is focused on the important task of standardizing medical codes to be used for social determinants of health and working to make data sharing easier. Thank you, fellow CSA members, for taking the time to listen to my lecture today. Before I conclude, I would like to take a moment to revisit the 3 learning objectives that I outlined at the beginning of this presentation. Define social determinants of health and explain their importance in healthcare. Describe the benefits and challenges of capturing, using, and exchanging SDOH data. And identify AHIMA's position on public policy regarding SDOH and discuss how current health policy advances those efforts. This video has provided you with a good foundation for learning about these topics, and I encourage you to learn more, like the range of Z codes in ICD-10-CM assigned to SDOH. Please reach out to me if you have any questions or suggestions on how CSA can better improve our own policies regarding social determinants of health. Thank you.